Again, welcome to the Parliamentary and Scientific Committee. We've had a series of virtual discussions over the last few months, not unsurprisingly due to the COVID restrictions, but what it has allowed us to do is to increase participation. So rather than being crammed into a relatively small committee room in the Houses of Parliament, we are able to open and throw our net somewhat wider. So you are all very welcome. The subject for this morning's discussion is the global perspectives, how UK and international researchers are working together to tackle COVID-19 across developing countries. And I'm very grateful to UKRI for their partnership with us on this occasion to put this event together. And to explore this subject, we have three excellent speakers. Professor Helen Fletcher, who is Director for International Development and Research at UKRI. Good morning, Helen. Welcome. Thank you for joining us. Professor Toby Peters, Professor of Cold Economy at University of Birmingham. Welcome, Toby. And Dr. Catherine Gallagher, Assistant Professor of Epidemiology, London School of Hygiene and Tropical Medicine. Welcome to you all, and thank you for giving up your time to join us. So, just before I invite each of our speakers to talk to us for approximately 12 minutes, a few of the usual housekeeping rules, which is please remain muted when you're not speaking. When we come to questions, which we will go to after we've heard from all three speakers, could you please use the Q&A function, which you can find, well, in theory, across the bottom of your Zoom screen. Please type your questions in there, and then we will marshal those and then come to each of you to invite you to ask your question in person. And when you do that, please could you state which organisation you are representing. Right, I think therefore without much more ado, we will go to our first speaker, which is Professor Helen Fletcher. Professor Fletcher, 12 minutes or so. Thank you.
Okay, thank you. Yeah, and thank you for convening this meeting and for inviting us here today to talk. So I'm going to give you an overview of UKRI's involvement in international research, so particularly in low and middle income countries focused on COVID-19. So I'm Director of International Development at UKRI, and I'm also a Professor of Immunology at London School of Hygiene and Tropical Medicine. So UKRI, so far we've actually invested more than £400 million of new funding into research, which is seeking to tackle COVID-19. So this funding has been focused across a spectrum of research, which is looking at technical solutions. So the robust treatments, for example, for COVID-19, looking at vaccine development and also improving the UK's vaccine manufacturing capacity. But in addition to that, UKRI is looking at the wider impacts of COVID-19. So we're looking at mental health, economic and environmental impacts, and also helping businesses as well to come up with innovative solutions. And the reason why we can have this breadth of research is because we have our 7 different research councils, also Innovate UK and Research England. So that means as an organisation, we feel we're really strongly placed to look at interdisciplinary research and the many different aspects of our life that have been affected by COVID-19. So as Director of International Development, I'm specifically looking after the delivery of the ODA research funds. So this is the official development assistance. And the funds that UKRI look after are the Newton Fund and the Global Challenges Research Fund. And this slide here gives you a snapshot of ODA research, which is happening across the UK government. So you can see that the Newton Fund was the first of these research funds to launch in 2014, goes through to 2021, and the GCRF came online 2 years later in 2016. So UKRI are not the only delivery partner for the Newton Fund and the Global Challenges Research Fund, but we are the major delivery partner for these funds, delivering about 60% of the Newton Fund and up to 80% of the GCRF. So the Newton Fund in particular has a focus on partnership and equitable partnership. And so this is partnerships which are government to government, funder to funder, and researcher to researcher. And we have partnerships with 17 middle income countries. They are agreements directly with the governments of those countries, with the UK government. And we work with research funders in those countries to actually help facilitate researchers in our 17 partner countries with UK researchers to primarily tackle research around the Sustainable Development Goals. And the idea here is that we match the strength of our research base in the respective countries with the development need of the country as well. And so you see an overlapping of where there's a need and where there are research expertise matched to be able to tackle that. So the GCRF is slightly different. So rather than having 17 specified countries with bilateral research partnerships, it's more of an open bottom-up research fund, but very much framed around the UN Sustainable Development Goals. And so what we're seeking to do with the GCRF is to really harness the UK science base to tackle global challenges. And we do this in 3 different ways. So first of all, we use our strong disciplinary research, but also our interdisciplinary research approaches to try and tackle those complex and interacting challenges. We also use this fund to actually strengthen the UK research capability, but more importantly, to strengthen capability in low and middle income countries to be able to have homegrown solutions for tackling challenges. And finally, the fund was established to respond in an agile way to emergencies and opportunities. And certainly the emergence of COVID-19 has probably been the defining emergency over the life of this fund. So how has COVID-19 impacted the world? Well, just last week, there was this publication, the UN Research Roadmap for COVID-19, which has really looked at the Sustainable Development Goals and looked at ways in which COVID-19 have impacted our challenges and how we should perhaps be doing research to tackle those. And so you can see that it's estimated that 71 million people are going to be pushed into extreme poverty in 2020 because of COVID-19. School closures have kept 90% of students out of schools for at least part of this year. We've seen increases in domestic violence of up to 30% in some countries, and some countries are seeing profound prison overcrowding, which are going to exacerbate the spread of COVID-19. So the GCRF and the Newton Fund are largely framed around the Sustainable Development Goals and actually trying to hit our targets for 2030 and make progress against these goals. So COVID-19 was very much something that we and others immediately recognised as something that is going to set us back and exacerbate inequalities. And so what we needed to do was to respond to that in a global way and contribute to the global effort to try and overcome COVID-19. So in UKRI, we've done that in 3 different ways. So we have the GCRF Newton Agile Response call. And so here, this was a call which we launched quite early on in the early summer, late spring, to address and mitigate the health, social, economic and cultural and environmental impacts of COVID-19. So far, we've invested £14 million into 40 different projects, and those projects feature in partnerships with 33 different countries and 60 different DAC list beneficiary countries. Another way that we worked was looking more directly at the health impacts of COVID-19, and we did that in partnership with Department of Health and Social, and that's with the MRC NIHR global effort on COVID-19. And with that, so far they've announced 12 awards, and of those 12 awards, 5 of them are led by principal investigators based in developing countries. Another way that we've worked, so we have, across UKRI call, we've got a cross UK government call, and we also have a call that's been in partnership with a research funder in low and middle income countries, and that's the South African Research Foundation led COVID-19 Africa Rapid Grant Fund. And so this is bringing together African research funders to look across the whole of the continent, delivering smaller scale projects to tackle COVID-19. So just to say a few more words on the GCRF Newton Agile call. So really there were sort of 3 major purposes for the call. So first of all, to understand and mitigate the direct impacts of COVID-19 on the most vulnerable people in developing countries. The next thing that the call was aiming to do was look at the secondary impacts of on the economy and the environment and education within these countries. And finally, we were looking to learn and adapt. So this is looking, what are the innovative solutions which are happening on the ground? How can we encourage the uptake of these, look at perhaps rolling them out in the region, or even learning from them for use in the UK and Europe as well. And it really recognizing that actually, if you look at many low and middle income countries, they've been living with diseases such as TB, HIV, malaria, Ebola for many decades. And so there are ways in which they were able to more rapidly respond than we were in the UK or in Europe, and potential solutions there, for how to sort of deal with this, how to provide social protection to each other within the community, how to protect yourself against disease, and also how to protect against those economic shocks that we really felt that we needed to capture with this research call. So that's just a brief summary of the work that we've been doing in UKRI to support research in low and middle income countries, and I'd be happy to take any of your questions.
Helen, thank you very much indeed. A very interesting presentation. As I said, we will take questions at the end, so please, if I could encourage people to put their questions into the Q&A. But perhaps just one quick question from me, well, maybe it's 2. One is, can you give any practical examples of where the money, the 14 million, I think it was, that was invested in the 40 projects for the GCRF, practical examples of how they had an impact and changed the way things were being done and who they helped? And also, you said in your closing statement that a number of the African countries, or countries that are used to dealing with some of these diseases or similar diseases, have we learnt anything from them that we could adopt here in the UK and put into practice?
Yeah, no, I think, well, first of all, for one of the practical examples, we have Toby Peters here today. His project was one of those that we funded in this particular call, so he can speak to that one. Another example is a call which was looking at helping parents to deal with children and adolescents who are going to be spending more time at home, and there may be tension and friction because of lockdown, because of economic worries, because of sort of general instability and insecurity in the home environment. And so working very closely with UNDP and UNICEF one of our projects led by a PI in Oxford called Lucy Cleaver. So she really sort of worked very closely with people in country and with UNDP to generate messaging for parents to actually help them to deal with the teenagers in the home and to try and sort of reduce conflict. That messaging was developed with great sensitivity to the countries where it was being rolled out, and they looked at various different methods to see which is the most effective way to deploy that. And so far it's estimated that they've got their messaging out to 80 million people, across an extremely large number of countries, and they've done that very rapidly over a period of just a few months. And I guess the reason why they were able to do that so quickly is because they did have a pre-established project. And one of the things that was important for this particular call is that we weren't looking to set up new partnerships. We were really looking to leverage existing sort of equitable partnerships, which we know worked really well to try and respond very rapidly to this crisis. But we could only do that because we'd had 4 years of previous funding where we'd really carefully, built up capacity, built up partnerships, and invested that time to do that. So yeah.
Thank you very much indeed, Helen. And as I say, encourage people to put their questions into the Q&A for you. Right, we will move on to our next speaker, which is Professor Toby Peters, Professor of Cold Economy, University of Birmingham. Professor Peters, approximately 12 minutes, please.
Thank you. Can you see my slides?
Yes, we can.
Excellent. Let's try that. There, perfect. So thank you very much, and thank you for inviting me here today. Yes, I'm the Professor of Cold Economy, which is about looking at how do we deliver our demand for cooling sustainably. So supported by UK research and innovation, I'm leading an international team of, I think, about 12 researchers to create a roadmap and a model for in-country COVID-19 vaccination cold chain design using Bangladesh as a case study. The teams from Birmingham, Heriot-Watt, BRAC University in Bangladesh, Bangladesh University of Energy and Technology, and industry partners. And what we're doing is we're gathering the data to design novel methods to assess Bangladesh's current cold chain capacity and try and seize this opportunity to align renewable energy and energy efficiency solutions with the mass vaccination of COVID-19 and also potential future needs. So our work specifically aims to explore the nexus between COVID-19 vaccine deployment, future needs, sustainable cold chain, and clean energy infrastructure development. And we hope that this project will assist policymakers in developing the most sustainable interventions to support the supply of COVID-19, but also increase resilience against other potential future disasters and epidemics. I think it will also support decision-making in selecting the new cooling equipment and indeed opportunities for modal shifts, potentially the use of drones, and look at how the equipment choices not only bridge gaps in immunization programs, but also could be repurposed and address the needs, including in other sectors like food after the pandemic, so thereby providing lasting legacy. So by way of background, an effective vaccine is seen as the world's best bet for overcoming this pandemic. And to date, the governments and the private sector have been investing heavily into the research and development of COVID-19 vaccines. However, achieving herd immunity means delivering these vaccines effectively to potentially 60 to 70% of the population. That means maybe 5.5 billion people. In the likely case that the vaccine requires 2 doses, that could mean 11 billion doses to be distributed. To put this in context, today we vaccinate 118 million children globally each year. Given the vaccines are temperature sensitive, achieving this successfully will depend on the robustness of the cold chain, how we move the vaccine from the manufacturer right the way through to the remote community. And I think given the volume and the speed required to get our economies going again, this is probably the single biggest logistics challenge the world has ever faced. Universal access to vaccines is an existing major challenge in low and middle income countries, mainly due to the lack of fully integrated functioning cold chains. In fact, it's estimated that about 3 billion of the world's population live in areas that don't have access to temperature-controlled storage to deliver the COVID-19 vaccine. And it's actually calculated that equitable distribution of the vaccine would prevent 61% of subsequent deaths, but were it to be distributed to high-income countries alone, that would only avoid 33% of deaths. Key barriers include insufficient capacity, inefficient cooling equipment, inadequate maintenance, lack of access to energy. And in actual fact, 25% of vaccines, 50% of vaccines in some countries are wasted globally due to broken cold chains. But even in those countries with robust vaccine programs, there's going to be challenges in managing this problem. India, for example, has the world's largest vaccine program and distributes 400 million vaccines a year, immunizing 56 million people. India plans to initially immunize 250 million people against COVID-19 in 6 months once the vaccine is available. Assuming a 2-dose vaccine, that's going to mean 500 million vaccine doses in 6 months against a current capacity of 400 million a year. In actual fact, some estimates are suggesting it will take until 2023 for India to achieve herd immunity, 800 million people, 1.6 billion doses. And let's not forget, existing vaccine campaigns have got to be simultaneously maintained. UNICEF, the WHO, estimate that up to 80 million children are already at risk of missing out on vaccines against vaccine-preventable diseases. Bangladesh, as an example, immunizes about 3.9 million children a year, equivalent to 2.4% of the population. But if Bangladesh gets a vaccine for COVID in January, the vaccine cold chain is going to be full of its measles, rubella, and other vaccines. In actual fact, UNICEF suggests that if 5% of the population alone is to be covered by 2 doses of a vaccine in Bangladesh, the country will need to double its current storage capacity. Bangladesh is currently looking to immunize 29% of the population. So you start to see the size of the challenge. And let's not forget, within this, whilst each country is quantifying the number of health workers required to immunize their populations, as we are doing in the UK, we need to also remember that a lack of qualified refrigeration engineers will lead to long response times to equipment malfunctions and broken cold chains. There's a big challenge. Given the fact that large proportions of the population live in rural, remote areas in developing countries, the key challenge for many of the areas is going to be the outreach and last mile delivery. This sometimes accounts for 50% of the country. Geographical barriers, poor infrastructure, lack of transport, bad road conditions already place burdens on the healthcare workers and reduce the inability to deliver frequent immunization sessions. And outreach is primarily served through insulated carriers with ice packs. So health centres won't only need vaccine fridges, but will also need freezers. Piece of good news we heard today is that whilst ultra-low temperatures of the Pfizer vaccine add a unique set of problems, we're seeing fridge-stable vaccines coming online, such as Oxford, which will be better suited for wider population coverage. This doesn't change the need for robust vaccine cold chain, but it's certainly going to make it easier. But there's a further dimension. Cold chains are energy intensive. They rely on refrigerants with high global warming potential. And given most of the technologies deployed today will still be in operation in a decade, if not longer, I believe that this rapid expansion must be made possible using technologies that are environmentally friendly. We've got sustainable solutions, but we have to start using them. We mustn't default to diesel-fueled temperature vehicles and diesel gensets for running fridges and cold rooms, which will then remain within the broader system for years to come. Solving this challenge shouldn't just be a case of increasing the capacity of non-diesel vehicles and vaccine refrigerators. It should also be looking at how we can change. And with the emergence of sustainable cold chain solutions, novel technologies, which unlock potential for modal shifts, such as drones, we can actually start broadening out our thinking and see how we can address this problem. And within that, how can we use synergistic temperature management services? Can we go into the food cold chain to deliver the solutions? But while the quantum of expansion may be estimated considering population size, the ground level conditions to sustain such expansion need to be better understood. And so this is what we are doing. To achieve our aim, we're applying a bottom-up whole systems approach, which includes getting the primary data from the communities and then using that to identify gaps, but then look at the possible solutions for COVID-19 vaccine delivery, and which, where possible, analysing by the economic, the environmental and the social impact of the current deployment plans if they're followed. And then using that information, we want to look at how we can scale up in a way which is environmentally, economically and socially sustainable and delivers a positive lasting legacy for meeting the goals and the targets, not just of COVID-19, but also the Paris Agreement and the Kigali Amendment to the Montreal Protocol. And as said, this work has to focus right down to the last mile of delivery. We think that this will actually develop formulation of effective strategies to help decision-making on sustainable technology choices and establish the recommendations for policymakers that don't just simply address the immediate need for mass vaccination, but also deliver national preparedness for future emergencies and disasters requiring cold chain, as well as meeting wider long-term cold chain infrastructure needs sustainably, particularly food. We'll also explore within this new logistics models, modal shifts, as I said before, and potentially how we can use drones, electric cargo bikes, and off-grid solar fridges for last mile outreach work. So in conclusion, in our project, we're addressing these two big questions. Can we develop a short to medium term crisis exit solution to deliver COVID-19 vaccine in a safe, efficient and clean manner while still maintaining other routine vaccine deliveries? How do we do this sustainably? But then we want to go this one step further, see how we can use this as a springboard to create long-term framework for cold chain logistics that is cost-effective, sustainable, and responding to future challenges. One point I'd just like to leave on is that for me, the cold chain is the third pillar of this COVID-19 vaccine. The first one was the design, second one, manufacture, the third one's the distribution. But let's not forget, alongside vaccines, we've got the disposable syringes, the PPE equipment, and all the supplies which are going to need to be shipped out. So along with designing how do we get it out there, we also need to plan the capacity to move everything back and ensure it's actually disposed of sustainably. So for me, the fourth pillar we now need to start looking at as well is the safe and sustainable waste management and disposal and recycling. Thank you very much.
Toby, excuse me, thank you very much indeed for that. I mean, obviously you've set out what a Herculean task it will be to scale up to vaccinate, well, potentially 11 or deliver 11 billion doses. And while one can put down on paper how that might be achieved, how do you actually achieve it in practice at the kind of scale that we would need to do and at the speed that we would need to do it, to be able to get that herd immunity, to be able to recover from this pandemic, and whose responsibility should that be? Is it individual governments, or do we need someone to take a global leadership role?
I think it's got to be collaborative. This is too big to solve in any one country, which is why I think it's great that UKRI is funding us and the UK to help solve this. Because also it's got to be collaborative in the sense that it's not just about the medical cold chain. We've got the food cold chain, so we can use their capacity if we understand it. And so that for me is, it's coming up to the system, because it's also, as I said, making sure that we don't put down a lot of vaccine fridges today, which are then redundant in a year or 2 years' time, but live there for 10 years onwards. So, and as I said, it's making sure we do this without using diesel gensets where possible. So, for example, we're doing a lot of work within this program with the World Bank. And as they look to fund it, try and get them to think, how do they fund solar? How do they fund new technologies? Not simply business as usual, because business as usual is not capable of delivering the speed and volume that this requires.
Thank you very much indeed, and I'm sure your comments will stimulate some further questions. I remind people to drop their questions into the Q&A. So again, thank you, Toby, for that. Right, and on to our third speaker, which is Dr. Catherine Gallagher, Assistant Professor of Epidemiology, London School of Hygiene and Tropical Medicine. Catherine, 12 minutes, if we could. Thank you very much.
Thank you very much, and thank you to the organisers for allowing me the opportunity to present today. I'm Kate Gallagher. I'm an epidemiologist at the London School of Hygiene and Tropical Medicine. I've been based in Kenya for 2 years, leading a vaccine trial, but I'll be talking today about one of the projects that the UKRI and NIHR have just funded through the GECKO call. This is a project that is a result of a real collaborative effort across 3 countries, and it will be looking at assessing the impact of COVID-19 on primary healthcare service provision and utilisation in Tanzania, Sierra Leone and the DRC. So, as I said, it was a real collaborative effort to put this in, and I'm presenting on behalf of the co-principal investigators, Ellie, Debbie, Hugo and Baila Lee. And it really fits with today's discussion, as the project is a real result of collaboration between research centres that were involved in the early Ebola vaccine trials. And these were set up with EU and CEPI funding, but they've now formed this platform by which we can further research proposals. So these are the various areas where we're proposing to work, and we're now starting to work, and where the institutes and partners are based. If we start with Tanzania, I was lucky enough to be based in Mwanza for my PhD research for 2 years, and this is a city that hosts the Mwanza Intervention Trials Unit. It's on the coast of Lake Victoria, with an urban centre that you can see in the photo in the top right, but then surrounded by semi-urban development along the lakeshore that you can see in the other photo, and then much more rural areas a bit further afield. In the DRC, we are going to be working with INRB, who are active in Goma, again, a city on the shores of Lake Kivu, but also surrounded by some very rural areas around it. And then in Sierra Leone, we are going to be working with COMAS, who are active in Cambia district, right on the border with Guinea, a very rural area. And all 3 of these countries hosted the Ebola vaccine trials. So we're using the same partnerships as developed under that setup. So in terms of the COVID-19 situation in each of these 3 settings, I've illustrated this slide with graphs just from Google, with the huge caveat that this is obviously based on and driven by the number of tests performed. But this is the data we have at the moment in terms of the COVID-19 pandemic in these 3 countries. In The DRC, there are just over 12,000 reported cases. So out of a total population of 90 million, that's 134 cases per million of the population. In Sierra Leone, it's just over 2,000 reported cases, which is 298 cases per million. And in Tanzania, there really hasn't been very much testing done. And so they've reported very few cases of COVID. There is a research group that has been looking at the extent of lockdown measures in each setting. And they've developed this Stringency Index, which is basically based on the reported implementation of lockdown. And the DRC is thought to have had the most stringent lockdown of the 3 settings, where they've had bans on gatherings of people, travel restrictions, stay-at-home orders, mandatory mask wearing, and a curfew was implemented in Goma in May. But the country has been gradually reopening since August. Tanzania has probably had the least stringent lockdown, with a few restrictions on schools and large gatherings, but limited change is evident in Google mobility data. And Sierra Leone is thought to be somewhat in the middle, with restrictions on large gatherings and travel implemented from March onwards, but has been opening up again since August. So with this context, why study the indirect effects of the COVID-19 pandemic on primary healthcare? We now know, and it's been known for a while, that the likely burden of the COVID-19 pandemic depends on the age structure of the population, and that the vast majority of fatalities are in populations over 65 years of age. So if you have a look at the table on the right-hand side, I've just summarized the basic demographics of a few countries. And in Tanzania, Sierra Leone, and DRC, the median age is between 17 and 19, which means half of the population is below that age. And only 3% of the population are over 65 years of age. This is a drastic comparison with countries in Europe and America, where the average age is much later, and more like 20% of the population are over 65. And so the younger population in these 3 countries that we're focusing on really indicates that there is a need to assess the impact of COVID lockdowns on the continuity of primary healthcare to avoid detrimental effects on non-COVID outcomes. So there is some evidence on routine services being disrupted during the pandemic, and the WHO did an early pulse survey of 105 countries. 68% reported some disruption of family planning services, 53% reported some disruption of antenatal care services, 42% reported some disruption of immunization services. And the level of disruption does correlate with income level. So low-income countries are much more likely to have had at least partial disruption than high-income countries. And in this graph, it shows 45% of low-income countries have reported at least partial disruption of at least 3/4 of their primary healthcare services. There is also some existing evidence on the impact of this disruption of routine services. So in the UK, there was reported 20% fewer measles vaccinations in the first month of lockdown. And there's been some modelling to suggest that the delay to non-essential surgery, especially cancer, particularly cancer surgeries in England, is predicted to have caused an excess number of deaths this year. In Uganda, there is some evidence to suggest substantial interruption of HIV testing and initiation of antiretroviral therapies in the first 3 weeks of lockdown, and a decrease in both Uganda and Nepal in the number of facility births, and a concomitant increase in maternal deaths and neonatal deaths at the facilities. So this project that we're just starting now has an aim to determine in what ways and to what extent the COVID-19 pandemic is having an impact on the provision and utilisation of primary healthcare services in Sierra Leone, Tanzania and DRC. And this is really the kind of process by which we have conceptualised the project, and we'll be looking at the mechanisms by which an effect could have had come about in terms of the factors influencing potential reduced utilisation, including changes in behaviour due to the lockdown, fear of contracting COVID-19 at the facility, misconceptions that the services are shut, but also reduced access options due to reduced transport during lockdowns or reduced disposable income. And we'll also be looking at some of the factors that could have influenced reduced provision. So the availability of the workforce due to being shifted to COVID wards or shifted out of the front line due to comorbidities, the ability of the workforce due to access to PPE or absence, and the workplace function, as in restrictions on service provision due to curfews or restricted hours of opening and access to drugs. And the projected impacts of some of this, so we'll be measuring the reduction in primary healthcare or the change in primary healthcare facilities by looking at antenatal care, routine immunizations, outpatient care, family planning, and HIV services. And there are a number of predicted adverse health consequences of a reduction of coverage of these services, including increases in stillbirths or miscarriages due to lack of identification of obstetric complications, and increases in vaccine preventable diseases, unplanned pregnancies and STIs, etc. So these are our planned activities. We'll be aiming to collect retrospectively data from the paper records at healthcare facilities in each region. So that is Goma in DRC, Mwanza in Tanzania, and Cambia in Sierra Leone for the services that I've mentioned. We'll be matching this with qualitative interviews with both the healthcare workers and the healthcare users, so members of the community around the health facilities, really looking at, with open-ended questions on whether there'd been any challenges accessing care or facilitators, and what were some of the mechanisms behind that effect. And we'll also be looking at how this relates to, in reality, the risk in that population of COVID-19. So we'll be looking at the healthcare workers' exposure to the SARS-CoV-2 virus through conducting 3 repeated serosurveys in the health facilities amongst the staff members to look at the presence of antibodies to SARS-CoV-2. So in the result of this will be a set of recommendations or key findings that will be formulated in partnership with stakeholders. And we're lucky in that through the Ebola vaccine trials, our partners are fully connected with the ministries of health where they are working. And we hope to feed these results back in real time and help the ministries of health formulate recommendations if there is an issue with provision of primary healthcare for this pandemic or one in the future. So I just want to say, acknowledge the team. It's a large team across many organizations, and thank you very much.
Catherine, thank you, excellent. And very interesting, obviously got a lot of work ahead of you. I was quite struck by the low case rate that you put up right at the start. And you mentioned that that was potentially due to low levels of testing. Are you, I mean, one, I suppose what you can measure is the sickness that people then succumb to and potentially requiring intervention, hospitalization. Are the figures genuinely much lower in these countries? And so therefore the impact on their primary healthcare system hasn't necessarily been justified based on the number of people who have got sick. It's more of a what's the word I'm looking for? Unforeseen consequence of worrying about it rather than the reality. Slightly garbled question, but hopefully you can understand what I'm trying to get to.
No, I know what you're meaning. I think there are so many factors that you've just touched on. The low case numbers are a result of lack of testing, but also a complex mix of sociocultural factors that might or might not prevent people coming forward for testing or reporting themselves as positive. And then also really the same mix of factors that might prevent them going to a health centre if they get sick or reporting the death if it occurs. So I'm based in Kenya at the moment, and there's very, very low reporting of or presentation to the health facilities of COVID cases, but we know that the seroprevalence is quite high in some settings. And so there's been a complex mix of factors that have prevented people coming forward. But if you take that away, even before the pandemic really started to spread across these settings, the predicted number of cases per million was always going to be lower than in Europe or the USA because of the different age structures. And if you assume that, that you've got kind of an equal mixing of the population, then your cases are on average younger, they're less likely to end up in hospital, more likely to be asymptomatic, and so less of a burden, although not insignificant.
Thank you. I'm glad you managed to understand what I was trying to say. So thank you for that. Right, we move on to questions now, and I have a few that have been dropped in. And the first one, we're going to go to Astrid Weisenberg. Astrid, someone will unmute you and then you can ask your question. And if I could remind you to say where you're from and if your question is just generally addressed to the panel or to a particular individual.
Hi, can you hear me?
We can.
Great. So my name is Astrid Wissenberg. I'm Director of Research at the University of Exeter. Helen gave a very helpful overview of the importance of GCRF funding, but at the moment that funding and the allocations for this year and indeed going after 2021 are quite uncertain. So I was wondering if there was an update available on the position around that. Thank you.
Thank you, Astrid. Helen, I don't know if you feel qualified to answer that.
Yeah, and well, I guess I don't feel qualified to answer that question. I don't, we are awaiting the outcome of a comprehensive spending review, as is every government department and every fund, be they ODA or non-ODA. So yes, I mean that hopefully by this time next week we'll have some certainty going forward. I think all we can do is really continue to demonstrate the impact of research on development, the fantastic strides that we've made in that direction over the last 5 years, and how we really intend to sort of continue on with the university sector to do that as best we can. But yeah, I mean, I have no more information than anyone else does, I'm sure, for the future going forward.
Thank you.
Thank you, Helen. Right, our next question is from Barry Brooks. Barry, welcome, and please go ahead with your question.
Good morning, Stephen and team. There's a very impressive scale and scope of scientific, manufacturing, engineering and logistic work, a real whole systems approach. Very pleased as an engineer to hear you describe that. I'm from the Worshipful Company of Engineers, but I'm also a director of Field Ventilator Limited. We're developing a ventilator for use in some of the countries you're talking about. But my question is about the marketing campaign. We see an awful lot of anti-vax messages over the internet these days. And unless they're overcome, isn't this going to inhibit the herd immunity objective of all of this work?
Thank you, Barry. Would anyone like to tackle that? Helen, please.
Yeah, I'll tackle this one. You know, partly as Director of International Development, but also as a Professor of Immunology at the London School of Hygiene and Tropical Medicine. My primary research area is vaccines. And yes, I mean, vaccine hesitancy, I think, is something that we have to take extremely seriously, both in terms of, you know, research and trying to sort of build understanding, you know, with that community, you know, understand why are people hesitant, and how, you know, how can we engage with them. Also, I think it's important that we understand, you know, with each of the different vaccine products that we've got, you know, what level of vaccination is acceptable within the population in terms of giving us some beneficial effective herd immunity. You know, we won't have to vaccinate 100% of the people, but we do need to have an understanding of, you know, what's our minimum criteria, and how hard do we need to work to reach out to those communities that might be more hesitant. Also, you know, vaccine hesitancy isn't uniform from country to country and region to region. You know, in many countries, certainly in many low and middle income countries, you actually see quite a high acceptance rate with vaccines, because, you know, people are living on a day-to-day, you know, generally they see a much more real impact of infection and the power of vaccination to improve quality of life and life course going forward. So yeah, I mean, you know, I think that, you know, it's something that we have to take very seriously, and we are investing research funding into that area. But I think we also have to listen to people as well. So I wouldn't want us to sort of dogmatically say absolutely everyone has to be immunized. There has to be a choice, you know, there has to be choice in that, and hopefully it will be informed choice. And I guess as research scientists and research funders, it's our job to help, you know, support that informed aspect of it.
Could I follow up, Stephen?
Sorry, yes, go on, Barry.
Yeah, I would suggest that there is quite a bit of urgency. It's not so much research as an active campaign, which is probably something that governments need to do in the UK for our own benefit, as well as working collectively across the world in the countries you're talking about. So I suggest there's some urgency, and maybe out of this session today, PNSC can help the government to bring that urgency to bear.
Thank you, Barry. I can, I mean, obviously, vaccine hesitancy is something that concerns me as well. And I have been talking both with the Health Secretary and with various immunologists about what we can do to get that message about what a vaccine is and it isn't across in a usable way. I mean, I think the vaccine hesitancy falls into two particular groups: those who are genuinely hesitant about the medical impact, the potential impact it can have on them as an individual and what the side effects are. Some are concerned about the pace at which this has been developed. We need to get across that we haven't cut any corners. It's just been done at a pace that has been running simultaneously, as opposed to running one step after another. And then there is the second group, which is far more difficult, who believe all sorts of strange things, that, you know, this is some sort of global conspiracy, that COVID's been invented to take away their rights and their powers, and you just need to see my inbox to understand that. And those people, I don't think, will ever be convinced that a vaccine can play a part in their lives to combat COVID. But what we have to do is make sure we can get across the science behind this and reassure people who would be open to it if they had confidence in it. And I was interested in Toby's comments that we probably need 60 to 70% of people to be vaccinated to create the right level of protection. There are others who say that should be 80%, but the recent surveys in the UK, I believe, say about 3 out of 4 people would be content to have the vaccine at the moment, which would sit squarely in that target zone. We just might need to do a little bit more to get it up to 80% if that's deemed to be the right level. I don't know, Toby, if you wanted to comment on that 60, 70, 80% level.
No, I mean, that's the information, the data that I'm being fed from the experts on vaccines. I'm just simply looking at how do you move it. Clearly, if you go up to 80%, then that's just going to increase the cold chain problem. But I'm sure Helen and Catherine are better placed than me on that number.
Would anyone like to comment, Catherine or Helen? Helen, do you want to?
No, I think, I think it's one of those areas where we will need to, as we see the level of efficacy that is reported on the different vaccine candidates, then that's going to help us inform what that number should be, as well as the understanding on the sort of transmission rate of the virus. But I'd say it's a little bit too early to say, because of course the efficacy data from the vaccines, we don't, it's still very early stage. Yes, the early efficacy data looks good, but what does it look like at 6 months? What does it look at 12 months? But for all of the factors that Stephen described, we'll have to go into that calculation to figure out what the actual percentage coverage will be in the population.
Thank you very much. Right. I will move on to our next question, which is from Neil Gaspar. Neil.
Good morning. Can you hear me?
We can.
Excellent. Hi, Neil Gaspar from AWE. That's a defence contractor. So many thanks to the speakers for this morning. I think my question is primarily aimed towards Toby, but any answers are received are welcome. So this effort for the cold chain is obviously immense. Would it have been better or even possible for the vaccines to be developed in the first place to be less or not at all temperature sensitive?
So it would be easier and cheaper to deliver a vaccine that isn't temperature sensitive, but I'm not qualified to discuss whether it's easier, cheaper to develop vaccines that are temperature sensitive and what that entails. I'm just working with what we have. And as I said, I'm really pleased to hear Oxford news today, because how we get a vaccine at 2 to 8 degrees out into low and middle income countries is seriously a lot easier than the temperatures we were talking about before. But as to that specific question, it's not my area of expertise.
Thank you, Toby. Would anyone like to, Catherine, or Helen, would you like to comment about why vaccines are developed in the way they are, and why some require really very cold storage and others can be stored at room or fridge temperature, perhaps I should say, rather than freezer temperature? Is anyone qualified to talk about the science behind that?
I can comment, a little on the science behind that. I think, from the perspective of an immunologist and sort of an early phase vaccine developer, the critical thing was to get a vaccine that worked, and absolutely, that had to be the primary focus. And I think it was, really right that we've had this very broad and productive vaccine pipeline, which is, covering the full breadth of platform technologies that we have, some of which are extremely new and cutting edge and have been untested. So the mRNA platforms, really new platform technology, the sort of small new bits of nucleic acid are quite unstable, which is why they need that very low temperature. But it was absolutely right to develop everything and use everything in our arsenal, because we couldn't afford to wait any longer. We have to get a vaccine, we have to get one as quickly as possible. Even if we were slowed and limited by how we deployed it, it was the right thing to do, to not limit ourselves to those which are have the stability in terms of temperature. But temperature stability is really important, and it may be that some of these new technologies, they are more stable than has currently been reported. It's just we haven't had time to do that testing, because it's only been sort of 6-8 months since they were first came off the laboratory bench and went into a product. So it wouldn't, I am sure that there will be fridge and freezers full of these different vaccine candidates sat now undergoing stability testing, so that we can really get to the to the full range of temperatures in which they can be stored. And but yeah, I mean, if we had the choice, then temperature stable candidates would be the way to go. But we just knew so little about this virus. We didn't have the choice, and we couldn't afford to wait.
Thank you. That's very helpful. Right. We will go to our next questioner, which is Anthony Kearns. Anthony.
Yeah, good morning, team. Can you hear me?
We can.
Oh, excellent. I have a question. I believe it's for Toby, and it's with reference to the cold storage, particularly in developing countries. Toby made a reference to diesel generators, I believe, to back up the cold storage facilities. And I wonder if consideration has been given to solar-powered generation with battery backup for these facilities.
Yes, absolutely. In actual fact, we go one stage further. So you have solar powered generation, but rather than using batteries as the backup, you use ice or phase change material as the backup. So Churchill, a UK company, has a vaccine fridge which can provide up to 10 days off grid using ice as the backup. So that's absolutely what I'm trying to do. Is I'm trying to get us to leapfrog to these new technologies rather than deploy diesel gensets and traditional devices. And that's also just quickly why, for example, drones I think are really interesting, because with a drone, you can actually move the vaccine good distance very quickly. So it can be kept cold just using insulation. You don't need to have vehicles. So again, that gives you the opportunity by using different bimodal shifts to actually negate the need for diesel vehicles. But you've absolutely hit the key point, is once you start looking at this as a thermal challenge, you can then start thinking in a different way, different technologies and different energy storage media as well.
Thank you very much. Excellent. Next question is from John Dewdney, is it?
Yeah, can you hear me?
Yes, we can.
Yes, my name is John Dewdney. I'm an individual member of the Parliamentary and Scientific Committee. My question is, to what extent do the panelists think that the recent G20 discussions on COVID actually gave them encouragement or help in what they're doing practically on the international scene?
Who would like to answer that? Helen, I don't know, what does UKRI, does it take a view on this?
Yeah, I mean, I suppose I'm sort of director of international development, so I'm always looking at things from the perspective of low and middle income countries, and I think global commitment, which includes the voices of low and middle income countries, is really important. Again, sort of going back to vaccines, there's a lot of discussion at G20, about sort of ensuring fair access and distribution, of sort of vaccine technologies there. So I think that something like the G20 and the G7, which is actually going to be hosted by the UK this year. So I think we have some more of an ability perhaps within the G7 to influence the agenda. I think that these fora do play really important roles, and I think COVID-19 and infectious diseases, they don't sort of stay within individual countries. They don't respect borders. They do, you need a global response, and you need and so these fora provide that ability.
Thank you. Right, our next question is from Tony Whitehead. Tony.
Oh, well, good morning, everyone. I'm Tony Whitehead. I'm an individual member also. You may feel that most of my questions have already been covered actually by Barry Brook, because my question was, how big is the problem of opposition to accepting vaccines? And I asked that question very conscious that this, of course, is a global problem. It's certainly not limited to developing countries. But also, I also have a sense it's been referred to as vaccine hesitancy. My impression is that in some parts of the world, it's rather more straightforward opposition. And so hesitancy doesn't quite cover the problem that I think we may see, that in some parts of the world, people absolutely don't want it for one reason or another.
Anyone want to comment? Helen.
Sorry, I'm jumping in. Yeah, I don't think. I mean, it's interesting. I haven't seen that from sort of thinking of my kind of history of working in vaccines. We see hesitancy, and there are some countries, as I said, that have higher level. Outright opposition within a country, I think, is rarer. I haven't sort of seen the latest, in particular relation to COVID-19, to see if we really are seeing countries opposing vaccination. I think that it's a good thing that we've got several different types of vaccine platform available. It might be that a particular country, doesn't like one platform, for a reason, either in the temperature it's distributed or how it was made, or perceived reactogenicity. It might be that they see that there's one platform which is more favorable than another. So having that diversity, I hope, would overcome some of that. But yeah, I mean, I think it would be very rare to see, blanket refusal of vaccines.
Thank you. Yes, I don't think it would be on a country level, but there were coordinated protests around the UK over the weekend, and one, it's against masks, it's against restrictions, it's against lockdown, but it's also saying it's against vaccines. But it is a very small number. It's whether or not they get any. Their credibility grows, perhaps, amongst those who are hesitant, which I hope it won't, which is why we, going back to an earlier question, need to get the right level of publicity and reassurance out to those who are potentially hesitant. But I think that is on its way. That's coming when we actually get to the point at which we start to roll out the vaccine and invite people to come and partake in the programme. So, but I mean, that's going to have to be done at speed. It's going to be within weeks that we've got to get on top of this. But I understand that the question, Tony. Right, our next question is David Slater. David? Hello, David.
Mute. Thank you, Stephen. My thanks to our speakers. Question, David Slater, Varley Engineering. Question mainly for Catherine, I think. If I've understood correctly, some of the COVID control measures that the countries that she studied have introduced have had perhaps perverse consequences, both in terms of the overall benefit to the community and also in terms of even pandemic control. And I wondered whether any of the governments concerned use anything like the UK QALYS system, which is, I think, quality adjusted life years saved to assess the likely benefits of pandemic control measures before they're introduced?
Yeah, that's a good question. They certainly use QALYs or are familiar with QALYs when assessing new vaccine introductions. And there are various modelling groups that have been feeding in economic and quality adjusted life year analyses, cost effectiveness analyses to the government previously to this. But I think the one thing I'm thinking of around COVID is some modelling work that was done by Abbas et al, looking at the quality adjusted life years lost due to certain levels of restriction on vaccine services, and the weighing that up with the risk of contracting COVID-19 at the health facility. And this was, I think, a few months ago, so potentially the modelling has moved on a little bit since then, but they estimated that across low-income countries, I think it was for every one COVID case contracted at the health facility, if you had a restriction of vaccine services by, I think it was 25 to 50%, you could, that could result in 146 vaccine preventable deaths. So there has been some attempt at modelling the relative risk benefit ratio of stopping routine services with risk of COVID. But it's very, very difficult to then validate those models because of the lack of data from the local population. So we're hoping to feed into some of that debate by actually assessing what's been happening right at the primary healthcare facility level, even if there's been government kind of push to continue routine services that might not have actually filtered down to the primary healthcare level because of restrictions of human resources, difficulties in accessing the drugs due to import difficulties during COVID. So we're trying to help build up a picture of what actually has been happening so that governments can then use that to weigh that data against some of the emerging data on COVID burden. And I think to do that, they'll need better data than the reported cases, but maybe using seroprevalence studies of the prevalence of antibodies would be useful for that, looking back at, at the last year. So a bit of they are familiar with QALYs. It would be a good thing to do, but I think we're restricted by the data that is available.
Thank you, Catherine. Thank you, Stephen.
Thanks, David. And yes, thank you, Catherine. Right. I have another question now from Trevor Crichton. Trevor.
Hello, I hope you can hear me. Just a simple question. How long does it take for a batch of vaccine to be started to the point when it is suitable or fit to be given to a patient? This could obviously impact on what the distribution network would need to comprise.
Thank you, Trevor. Would anyone like to offer a view on that? I see you've unmuted, Helen.
Happy to step in again, yeah. I mean, that's a difficult question because unlike drugs, vaccines tend to be very individual. They are, they're bespoke, and they are, each vaccine platform is going to take a different length of time to manufacture. It's going to require, different types of test in terms of safety and stability before it can be signed off for use. you know, for absolute sure, what's been phenomenal over, you know, this last 9 months or less is the accelerated way in which, you know, industry and academia and, you know, and other actors have really, and regulators have worked together to accelerate the production of those and sign off of, if you like, of those vaccine batches as fast as they can. I mean, there has been a real focus in it to be, you know, to try to be able to do that. I know, for example, that you know, Pfizer were aiming for sort of 100 million doses in 2020 and then 1.5 billion doses by the end of 2021, just to give you sort of a feel of the scale and the speed of which these vaccine batches are going to be produced. And obviously, you know, that's just one manufacturer, and now we have several of those platforms online. So I think, you know, incredibly, you know, what COVID-19 has shown us is that we can actually do these things quite quickly. So and much faster than we've ever done them before, and I'm sure that will continue as long as there is a need for these candidates. Yes, and then you know, and that sort of, and then you know, after manufacture, then the problem translates to Toby and his, you know, his cold chains and how they actually adapt, you know, to each of these products, which might have slightly different requirements, because that's going to be the challenge for distribution as well. It's not just that you've got one vaccine which has to be held at -20. You may have 3 vaccines or 4 vaccines that all need to be held at different temperatures.
Thank you. And I think there is the follow-on question from Colin Danson deals or touches upon some of that. So Colin, I don't know if you're there.
Yes, I'm here, Steve. I'm Colin Danson. I'm from AWE, Defence Contractor. I was interested if there'd been modelling on the effectiveness of the vaccination in different population densities. So, and which would affect the cold chain delivery, obviously. If the vaccinations are centred on large population densities, how effective would that be to especially third world countries, and you know, limiting the vaccinations to those population densities where the cold chain may be easier?
Okay. Toby, I don't know.
Well, I mean, I'll just jump in quickly. I mean, we will be looking at that as we do the research once we're gathering the data. The only thing I would remind people is that in the low and middle income countries, you know, the majority of people actually live in the rural communities. So India is India, Rwanda, countries like that, Bangladesh, are all over 60% of the population is rural. So focusing on the urban actually doesn't get to the majority of people. But so that's why we're looking at those areas, because obviously we've got to get it out to get the communities kick-started.
Thank you. I don't know if anyone else wanted to add anything to that. No? Okay. I think the point about, yes, the type of countries where you're trying to deliver this being very rural is well made. So thank you for that. And I think, unless I'm mistaken, our last question, the last one I've got at the moment, is from Cherry Tweed. Cherry.
Hello, I'm Cherry Tweed. I work in the Government Agency for Radioactive Waste, so quite a distance from vaccine. But my question was, how important is it for us in the UK to see successful vaccination programs all around the world? And what's the risk if we don't?
Helen first, I think. We'll come to each of you to just give perhaps a comment on the question, and then maybe a final thought that you want to leave us with. So we'll start with Helen.
Yeah, I mean, we are an interconnected world and an interdependent world, and I think COVID-19 has really highlighted that. And you know, the work that Catherine is doing, the work that Toby is doing, you know, we can see that if we have a problem in one country in terms of an infectious disease or a pandemic that might be impacting their economy, but their exports, you know, their health, then that's not going to stay in that country. That, you know, that problem is going to have a ripple effect in the region, and then will very quickly have a global impact as well. And I think, you know, if anything, sort of development research over the past sort of decade has shown us that we are a really, you know, interconnected and interdependent, and you know, a problem in another country is a problem in our country, and so, you know, a solution in one country is then you know, a solution in another country as well.
Thanks, Helen. Who would like to, perhaps a comment from you, Toby? Maybe not directly answer the question, but no,
I mean, I fully agree. It's about, you know, this is a global community. We are dependent on the global community for our food, many aspects of life. But this also comes back to the point that I think, which is really important, is that in solving the challenge of COVID-19, and from my perspective, the cold chain, you know, this is the demand for cooling is only going to grow. The demand for cold chain, you know, we lose in 600 million tons a year of food globally because of lack of cold chain between farm and market. So as we drive to feed the world, to live as a global community, we have to make sure we look at these in a joined up way. I mean, 80% of our fruit and veg, or 80% of our food and 50% of our vegetables are imported. So we need to have a working global community.
Thank you for that. And a final thought from Catherine.
Yeah, I totally agree with Helen and Toby around the need for global access. I think I would add that in many low-income countries, there isn't yet a platform for adult vaccination. So there's not a routine flu vaccine program, so that needs to be developed. And the demand does need to be driven in that age group. But also, I think the vaccine delivery does need to be targeted. You know, the at-risk, the vulnerable population is a lower proportion of the population in low-income countries. It still needs protecting, but there are other diseases that are also massive, have massive burden, and we shouldn't forget about them.
Indeed, indeed. Thank you all very much indeed. And along that point, I've got an observation here from Tim Julia, who says it's remarkable the speed at which a COVID vaccine has been developed when we put our collective minds to it. And I suppose his question is it naive to think that that kind of dedication and force can be put to address other diseases, other challenges such as climate change, cancer, HIV, etc. So, I mean, I think it's an observation, and I'm not going to ask for any further comment, but it's a well-made observation. I think it's been an absolutely excellent discussion this morning, really interesting, and I think it's certainly got people thinking, as we can tell from the questions. So thank you very much indeed to our three speakers, to Helen, to Catherine and to Toby for their time this morning and for sharing their thoughts with us. Can I also thank Roxy Squire and her colleagues at UKRI and UKRI, of course, for partnering with us on this. Thank all of you for attending and asking your questions. And of course, to my team at the Parliamentary and Scientific Committee, to Lee Jeffs, Karen Smith and Ben Allen for organising the event, and Charlotte Hall, Charlotte will be here somewhere, who is going to be writing up the notes. So thank you to all of you. Our next meeting will be a fortnight today, Monday the 7th of December at 10:30, when we will be discussing autonomous transport, and that may well include some of the ideas that Toby was talking about in terms of drone deliveries of vaccines, but we will wait and see. But you're all warmly invited to come along and join us for that next meeting. Until then, have a good couple of weeks, and I'll see you all again soon. Thank you. Bye.